Assalamu alaikum friends. Welcome to my channel Orthopedics Made Easy. So just to remind you why my topics are important, they are very concise and exam oriented. They are very interesting and simple presentation and only one topic is covered in each video. So you can see topic of your choice anytime. So we'll move on to the today's presentation or today's class. So we'll start with the today's case. It's a 60-year-old female patient. So this age is very important here, and she fell on the ground. So it's a just household injury. And after the fall, she noticed a swelling around the shoulder joint. So, and she feel that the shoulder is locked. There is no movement around the shoulder joint. So this is the presentation. And she also have numbness along the upper arm region. This point is also very important. So it's an old lady with the shoulder injury, locked shoulder with numbness around the shoulder region. So this is the mechanism of injury here. She was just walking, she fell down and the limb went into abduction and external rotation. So the shoulder joint given way and the head of the humerus got displaced anteriorly out of the glenoid cavity. So this is a classical presentation of shoulder dislocation. To specify anterior shoulder dislocation. Shoulder dislocation. So shoulder dislocation, otherwise called dislocation, it's otherwise called as luxation. Subluxation is a partial dislocation. It's not a complete, whereas luxation is complete dislocation. So how will you define the dislocation? Complete loss of articulation. That is joint contact between the head of the humerus and glenoid cavity. So its patient is having this complete loss of articulation between the humerus and the glenoid cavity. We call it as shoulder dislocation. So shoulder is the commonest joint to dislocate. So 50% the dislocation happens in the shoulder, followed by patella, followed by elbow. So shoulder is the commonest joint to get dislocated. And in children, in adults actually. In children, elbow dislocation is the commonest dislocation. So out of the shoulder dislocation, 95% is anterior. And in 95%, the maximum is subcoracoid. These are the common questions asked in your PG entrance. So common dislocation is shoulder dislocation in adult. In children, it is an elbow dislocation, whereas 95% of shoulder dislocation are anterior dislocation, and among this, the subcoracoid variant is most common. Very few are posterior dislocation, and least is the inferior dislocation. So we need to know the terminology, what is recurrent shoulder dislocation and what is habitual shoulder dislocation. Recurrent shoulder dislocation is the shoulder is dislocating more than one time. So it's a painful condition, whereas habitual dislocation due to inbuilt laxity of the ligament, patient himself can dislocate and relocate. So it's non-painful. So this is all about recurrent and habitual dislocation and how common the different type of dislocation is. So this is a pictorial diagram where if you see there is articulation between the glenoid and the humerus. In dislocation, what is happening is this is moving down outside the glenoid cavity. So there is loss of articulation here. So this is your dislocation. So this is about the mechanism of injury, then different type of dislocation and the how dislocations are common. So just here the points to concentrate is shoulder dislocation is most common, followed by patellar dislocation, followed by your elbow dislocation. And among the shoulder dislocation, anterior dislocation is most common, and among the anterior dislocation, subcoracoid variant is more common. We'll move on to the next slide. Here is the normal anatomy of the shoulder joint. So if you see, I mean, it's just now we have done the it's a shoulder is humerus and head articulation with the glenoid. Okay, so it's a ball and socket joint. So if you see the anatomy, we have stabilizing structure for the shoulders. So one is the bone itself. So bone is concave like this. And to increase the depth, we have the glenoid labrum. So glenoid labrum, it increases the depth of the shoulder joint by 50%. So there is increase in the 50% depth of the shoulder joint secondary to the glenoid labrum. Then the other structure we stabilize the capsule and ligament. So capsule around the shoulder joint and the ligament around the shoulder joint also increases the stability. So we classify the stabilizers of the shoulder joint as static stabilizer and dynamic stabilizer. Static stabilizer means they won't contract or they won't relax, they stay in the same position. So out of that, we have the ligaments here. So the ligament starting from coracoid process to acromion. So this is coracoacromial ligament. Then one ligament starting from the coracoid to humerus. This is two ligaments. So coracoacromial ligament, coracohumeral ligament. Then the third one is the capsule. What is happening is capsule is getting thickened in between. So this thickened capsule, it also gives support to the joint or give stability to the joint. So these are the four capsular ligaments. One is it's starting from glenoid and going to humerus. So this is uppermost. So superior glenohumeral ligament, medial glenohumeral ligament, and inferior glenohumeral ligament. And there is one ligament going all the way from the humerus to down that is called as spiral glenohumeral ligament. So we have just I told the three important ligaments here. Two ligaments are starting from coracoid. So coracoacromial ligament and coracohumeral ligament. And the four ligaments are condensation of capsular thing in the form of ligaments. They are superior glenohumeral ligament, inferior glenohumeral ligament, middle glenohumeral ligament, and spiral glenohumeral ligament. So if you see here, this is this is coracohumeral ligament, coracoacromial ligament, glenohumeral superior, middle, and inferior. Then glenoid labrum, as I told, it increases the depth by 50%. And there is negative pressure inside the joint, which also give stability. Then we have dynamic stabilizer. In the last class, we have done with the rotator cuff injury. So rotator cuff anteriorly, if you see how the rotator cuff is. So if this is the shoulder joint from the side view, then if you there are the rotator cuff covering the joint. It's like anteriorly we have subscapularis, then superiorly supraspinatus. On the posterior side, we have infraspinatus and teres minor. So they when they contract, they push the shoulder joint and maintain the shoulder joint inside the glenoid. So this rotator cuff give dynamic stabilization. They give stability whenever the shoulder is moving. And we have a long head of biceps. This is the long head of the biceps going all the way like this. So this long head of the biceps also give stability to the shoulder joint. It prevents shoulder joint. It pushes the shoulder joint inside whenever patient is moving the shoulder. So this is the long head of the biceps going like this. So to just summarize, we have stability in form of static stabilizer and dynamic. Static stabilizers are two ligaments starting from the coracoid and four ligaments. They are condensation of the capsule. Whereas in dynamic stabilization, we have we have rotator cuff and we have long head of biceps. So with this anatomy in mind, we'll move on to the different. One more thing to tell you, what are the structures near the shoulder. So we have one very important structure, that is your axillary nerve. So axillary nerve just lie around the surgical neck of the humerus. So any fracture or any dislocation of the shoulder, it stretches the nerve or it may cause damage to the nerve, resulting in neurological deficit. If you see here, this is your bone, and here is the brachial plexus. Axillary nerve is coming like this. So it supplies one deltoid, second teres minor, and it has a cutaneous nerve which supplies the skin around the proximal part of the arm. So this is very important because when there is dislocation, there is pressure over this nerve. If there is a pressure over this nerve, there is muscular function damage and there is loss of sensory function. But and the dislocation or fracture case, due to the loss of anatomy, the muscle contraction cannot be elicited. So we look always for the sensory supply of the axillary nerve. Sensory supply is very important of axillary nerve. So when patients come with dislocation or fracture around the shoulder joint, always check for sensory supply. We can't elicit the motor supply. It's a sensory sensation we need to elicit. We need to look for the sensations of the axillary nerve. So it goes by regimental badge sign. So this is the army people. They have they wear regimental here. So that area will get anesthetized or hyperesthesia along that area. So this can be elicited by needle or some needle prick or needle sensation. So this is regimental badge sign. So one point here I just want to tell you is axillary nerve is the commonest nerve followed by musculocutaneous nerve. So second most common nerve to get involved after the shoulder dislocation or proximal humerus injuries is musculocutaneous nerve. It's first is axillary nerve. So and it goes by name regimental badge sign. So anterior dislocation. Anterior dislocation is very important topic for you for your theory exam, practical exam, even for a lot of questions will come in your PG bit. So they are, this is a normal shoulder joint. If you see this, the head of the humerus articulating with the glenoid. So we have three important structures here. One is clavicle, one is coracoid, and one is glenoid. So here is glenoid. So after the dislocation, the head will move in any of down to any of this bony structure. So subcoracoid means here head is dislocating and coming and hitching at the coracoid. So it's a subcoracoid. Here subcoracoid. So this is most common. So we have CO common. CO common. With this mnemonic, you can remember which is most common. Subcoracoid common. Then it with the head may go out and just locked below the glenoid. So it's called subglenoid. The same way it may go more medially and just hitch around the clavicle. It is subclavicle. Very least common is head may enter into the thoracic cavity. It is called as intrathoracic. So we have subcoracoid, which is most common, followed by subglenoid, followed by subclavicular, followed by intrathoracic. So these are the variant of the anterior dislocation. So what is the mechanism of anterior dislocation? We have this as a bimodal distribution. In very young people, we have this injury. Old people also we have injury. So in young, contact sports is most common, whereas fall in the older patient with head is going with the arm going into abduction and external rotation. This is the mechanism of injury. So here I try to explain you the mechanism of injury in the contact sports where the shoulder is getting pushed in the abduction and external rotation and head is hinging out of the humerus. Whereas it's a very trivial fall with the abduction and external rotation in older age group. In shoulder dislocation, always you will be asked regarding these two types of injuries. One is called as Bankhart's lesion, other is called Hill-Sachs lesion. This is your Bankhart's lesion, this is your Hill-Sachs lesion. What exactly it is? So what happens is when shoulder move outside here, if you see this is here, what is happening is shoulder is moving outside. When shoulder move outside, it lifts the periosteum along with the labrum. So this is called as Bankhart's lesion. When it comes out, then this part of the head hitches over the corner of the glenoid. So it get dent or depression. This is called as Hill-Sachs lesion. So hope I am clear to you. Hill-Sachs lesion is over the head. H for head. Hill-Sachs lesion. Head of the humerus. Hill-Sachs lesion. The opposite is Bankhart's lesion. It is happening over the glenoid labrum. So these two lesions are very important in your exam because you need to remember, and these are the causes of patient having recurrent dislocation. So head is Hill-Sachs lesion. Glenoid is Bankhart's lesion. So this is again the same diagrammatic representation here. What is happening in Bankhart's lesion? So Bankhart's lesion is glenoid is getting separated from the glenoid. Glenoid labrum is getting separated with the bony attachment. So here, if you see the glenoid, the head has humerus has moved outside along with damaging the margin of the glenoid. So this is Hill-Sachs and Bankard's lesion. So how Hill-Sachs lesion cause, how Bankard's lesion cause recurrent dislocation is Bankard's lesion decreases, as I told, glenoid give 50% increase in the depth of the uh, depth, increase 50% increase in the depth of the glenoid cavity. So what is happening here is due to this loss of glenoid. One second. Loss of glenoid, the depth is gone. So once the depth is gone, then there is instability. Whereas how the Hill-Sachs lesion is causing is what is happening in Hill-Sachs lesion. If you see here, there is a dent here. So this dent, whenever shoulder is going into, normally the shoulder should rotate like this in external rotation. What is happening is this is your dent, this is your Hill-Sachs lesion. When shoulder is going into external rotation, it is coming in opposition with anterior part of the glenoid margin. So this is hitching this one, and it is fulcrating it out and causing redislocation. So this is how the Hill-Sachs lesion and Bankard's lesion causes recurrent dislocation. So this is all about Hill-Sachs and Bankard's lesion. Then what are the specific tests for shoulder dislocation? So these are very important. One is Hamilton ruler test. The other is Dugas, Calvé's, Behrens test, and arm length. What is Dugas test? Dugas test is we ask the patient to touch the opposite shoulder by keeping the elbow over the chest wall. So if there is a dislocation, the patient will have abduction deformity. So he won't be able to do the opposite movement. So adduction and internal rotation is not possible. So if it is not possible, that indicates that there is some loss of contact between the articular surface. So this is one sign. This is called as Dugas test. Other is the it's in chronic dislocation, we have sulcus sign. This is not very important. Then we have Calvé's test. What is Calvé's test is when you measure the circumference of the shoulder like this, circumference of the shoulder, due to dislocation, it increases. So this is how I'm trying to, this is a clavicle, this is acromion, this is the shoulder joint, and this is your humerus. So when this is the normal circumference in the axilla. If this is the axilla, this is a normal circumference. What is happening here is due to the dislocation, the circumference is increasing because head of the humerus is outside. So this, whatever you are measuring, it will measure all the three component glenoid, head, and acromion separately. So this is called as Calvé's test. So there is increase in the circumference of the shoulder joint. Then comes your Hamilton ruler test. This is your Hamilton ruler test. If you keep the Hamilton any ruler over the lateral end of the acromion, generally it won't touches the lateral epicondyle. But here what is happening is the shoulder is moving inside. So once head of the humerus inside, this counter is gone. Once this counter is gone, if you keep the ruler here, it will touch the lateral epicondyle. This is called as Hamilton ruler test. Then there is the other last one is called as Behrens test, where the anterior axillary folds moves a little down because the shoulder has moved out and down. There is the anterior axillary fold will when compared to the normal side, it moves down. So with this, what are the investigations we do? We do the X-ray to know the alignment. If you see X-ray here, normally in the X-ray, the glenoid should cover 1/3 of the head of the humerus. So here, what is there? The glenoid, then head is lying down. So this is your acromion. So this is subacromion dislocation. Then CT scan to know the three-dimensional, what happened into the head of the humerus. This is for the anatomy of the humerus, we do CT scan. The third one is we do MRI to know the labium. So X-ray, CT scan, and MRI are the investigations we do to know the pathology in the shoulder dislocation. So what is the treatment? Once patient comes up, we need to reduce it as early as possible. So you can either give sedation, anesthesia, or intra-articular xylocaine injection and reduce it. Then what are the methods of reduction? So there are a lot of methods of reduction. We have four important. One is old Hippocrates method. Second is Cocker's method, commonly asked. Then Stimson's gravity and traction and counter traction method. So we'll brief about each method and we'll finish the today's class. So this is your Cocker's method. Cocker's method is very important. What we do in the Cocker method, you remember by mnemonic T India. So T is we will give traction in line with the deformity, then we'll do external rotation, then we do adduction, then we do internal rotation. By this, the shoulder should get reduced. So if you see here, this is the position of the shoulder. So we do first, we'll give traction in line this one, traction like this, and we go for external rotation, traction, external rotation. Then we are adducting it, then we are internal rotating it. So this series of movements are very important and it will be asked in your exam also. So how will you remember T India? Traction, external rotation, adduction, ADD, adduction. It's adduction and internal rotation. The second method is Hippocrates method, where so the person who is reducing the shoulder will keep the feet or heel inside the axilla and use it as a fulcrum and give traction and reduce it. But it is very dangerous method of reduction because there is high risk of patient developing brachial plexus injury, and also patient may have fracture around the neck of the humerus. So it's not practiced now, it's just for the mentioning here. The third one is Stimson's gravity. In very old patient, osteoporotic patient, you are afraid of doing any maneuver because in osteoporosis, there is high risk of patient developing the fracture. Then we use gravity to help reduction. So what we'll do is we'll tie some weight and slowly increases the weight. So due to the action of the weight and the opposite action of the body, the shoulder will fall into the place by itself. It's old age where there is osteoporotic bone. Old age osteoporotic bone, we use this. Then the last one is traction counter traction method. We get one will be holding a towel through the axilla and giving the counter traction. Other one is holding the hand and pulling it out. So these are the various method of reduction of the shoulder, acute shoulder dislocation. What are the complications? We have complications. A patient will have recurrent shoulder dislocation. The second is patient will have recurrent shoulder dislocation secondary to Hill-Sachs lesion that happens in the head of the humerus or Bankhart's lesion along the labrum. Patient may have associated rotator cuff injury. If the reduction happens after we delayed reduction, then patient may have arthritis due to the cartilage damage. And if there is a pressure over the neurovascular structure, patient will present with brachial plexus injury and all. And sometimes patient will have associated fracture around the proximal humerus. So these are the complications patient may have after shoulder dislocation. So thank you for listening. Please like, subscribe, and share the video. This is very important topic.